I'm Dr. Sudha Seshadri. I'm a professor of neurology and director of the Glenn Biggs Institute for Alzheimer's and Neurodegenerative Diseases at the University of Texas Health in San Antonio. I'm also a senior investigator at the Framingham Heart Study in Boston, Massachusetts, or Framingham, Massachusetts, where I lead the study of stroke, dementia, and brain aging. One of the insights that we have in the past 10 years from the repeated failure of multiple medications aimed at lowering amyloid levels, which have not resulted in improvement in the progression of disease or cognition, is that what we clinically call Alzheimer's is not something simple and not something that has only a single biology in every patient. Another big component that's there in almost every person who comes to clinic is some degree of vascular brain injury. The lifetime risk of hypertension for a 55-year-old, as shown by Framingham data, is 90%. And so between the various types of vascular factors, ranging from obesity, insulin resistance, hypertension, diabetes, and hyperlipidemia, there is some degree of vascular injury in almost everybody. About 30 years ago, the definition of vascular dementia was if you had multiple strokes and multi-infarct dementia. But starting in 2000, with the NIN-CDS, the CSN criteria, the vascular harmonization criteria, the definition changed so that all it required was that there be disease of the blood vessels or the blood supply to the brain, some injury to the brain parenchyma, and some degree of cognitive dysfunction that could be attributed to this. By this definition, almost everybody has some degree of vascular brain injury, as well as varying types and extents of neurodegeneration. And it's really the combination. Just last week at the Biggs, we have a brain bank where we correlate the clinical picture before, during life, including the imaging, with what we see at pathology. And 3 people, all of whom had classical clinical dementia of the Alzheimer's type, when we looked at the brain, they met all the criteria for pathological Alzheimer's of the dementia type, but each one of them had multiple other neurodegenerative etiologies, as well as varying amounts of either small vessel disease or large vessel disease. So this intersection between stroke at one extreme and pure amyloid and tau-related diseases at the other extreme seems to be very important in us effectively tackling clinical dementia in people across a wide age range. It's less clear how important the vascular factors in the oldest old, above the age of 85 is. But by that, what I mean is their vascular exposure during their midlife years is very important. But what your blood pressure is when you're 85 may be less important. We have had this year a series of very exciting findings, including from the Sprint Mind, that showed that controlling not just hypertension, but controlling systolic blood pressures, even in what used to be considered a normal range, between 130 and 140 millimeters of systolic, can decrease the chances that somebody will develop a mild cognitive impairment. And we have other studies showing that there is overall an impact of just effectively controlling blood pressure, but in addition, certain medications may be more effective than others. Another thing that's very interesting is that variability in the heart rate, in the blood pressure, which may be a sign of disease in the brainstem, also seems to be a marker of later development of dementia. So it's not just the conventional vascular risk factors, but also the autonomic dysfunction that may be an early marker of dementia. So what does this mean for a practical, in a practical public health point of view? It does suggest that, broadly speaking, what's good for the heart is good for the brain. There is the American Heart Association Simple 7 criteria that says exercise, controlling weight, blood pressure, lipids, not smoking, that these 7 factors, if they are in an optimal range, we find that between people who have all 7 in an optimal range and only 1 in an optimal range, there's a big difference in the risk of dementia. This was shown by the 3-city study, for instance. There's also a difference in just the volume of the brain. In Framingham, it was about a 3 years difference in the size of the brain. So if you were 57 years old, your brain was like somebody who's 54 if all these were in the good range. This is broadly speaking. The specifics of what kind of exercise, who is it going to help most, what kind of lipid lowering, who is it going to help most, these are things that are still being worked out through more observational studies as well as through clinical trials like the Worldwide Fingers, the United States Pointer study, and other sort of multimodal as well as single mode lifestyle intervention studies.